Good evening. So we will discuss about the blood and blood products and their relative pathology in critically ill patients one by one. So in most critically ill patients, transfusion trigger of Hb less than 7 grams per deciliter is taken. It is based on the transfusion trigger in critical care and transfusion trigger in septic shock trials, which are well recognized trials. However, in patients of coronary artery disease and acute coronary syndromes, instead of this 7 gram per deciliter, we take a liberal transfusion trigger of 10 gram per deciliter. And it has seen that when we take this liberal transfusion trigger of less than 10 grams per deciliter, the patients have got increased survival. Each unit of PRBC, that is packed RBCs, contains approximately 300 to 400 ml of volume, and it decreases hemoglobin by 1 gram per deciliter and hematocrit by 3% in an adult without ongoing blood loss or blood destruction. In case of emergency situations, if the crotch match is not available, we use O negative RBCs. Now let's see the type of RBC product. Whole blood is not used nowadays. It contains all the components. It is used only in cases of autologous donation prior to surgeries. Packed RBCs, as I've told you, it contains 300 to 400 ml of volume and a hematocrit of 60%, and it also contains approximately 200 milligrams of elemental iron. If we gamma irradiate the blood, that is, if we destruct the donor T lymphocytes, it is known as gamma irradiated PRBC. It is used to prevent graft versus host disease in patients who are immunocompromised and in stem cell transplant patients. CMV antibody negative blood is used in transplant patients and in pregnant patients where risk of complications are high if they get infected with CMV. Leukocyte depleted blood prevents leukocyte immunization in hematological malignancies. And if RBCs are washed with normal saline prior to transfusion, that is to remove donor serum, and they are used in IgA deficient patients and in patients with paroxysmal nocturnal hemoglobinuria. Now, platelets are prepared by centrifuging the whole blood which we have collected and which separates the platelet-rich plasma from the rest of the components. RDPs, that is the random donor platelet concentrates, contain about 60 ml of plasma and increases platelet count by 5,000 to 10,000. Usually a figure is given in questions like 7,000, 8,000. So it is a right answer. It increases the platelet count by 5,000 to 10,000. RDP, one bag of RDP. The survival of this RDP is 3 to 5 days at room temperature, and it should not be refrigerated because if we refrigerate the platelet lose their shape and release the granular content. So it is no more useful. Apheresis is done to collect the single donor platelets and is equivalent to 5 to 6 pooled units of random donor platelet compounds. So this single donor platelet contains about 200 to 400 ml of plasma. This amount of plasma is important because it can increase the fluid. Now, when do we call thrombocytopenia? Normal platelet count in a healthy adult is 1,50,000 to 4 lakh. If it is less than 1,50,000, we call it thrombocytopenia, and incidence is about 20 to 25% in ICU patients. As per the PROTECT trial, they define this thrombocytopenia into mild, moderate, and severe. Mild is when the platelet count is between 1 to 1.5 lakhs. Moderate is when it is 50,000 to 1 lakh. Severe when the platelet count is less than 50,000. If we see the individual incidence of thrombocytopenia, is 15.3 for mild, 5.1% for moderate, and in 1.6% for severe. So you can see that almost 20% of our ICU patients have thrombocytopenia at one or some other time. If a patient has got thrombocytopenia, the patient has higher ICU mortality and longer duration of mechanical ventilation. In circulation, the platelets half-life is 7 to 10 days, and one-third of the platelets are sequestered in spleen under normal conditions. Now, absolute platelet count is important, but the trend is more important than the absolute platelet count, and a declining trend may give evidence of serious clinical problem like heparin-induced thrombocytopenia. Bleeding occurs when platelet count reaches less than 50,000 in post-surgical patients, and for spontaneous bleeding, the threshold is less than 5,000. Clinical recognition of cause is vital as therapy depends on the etiology of thrombocytopenia. What are the common causes of thrombocytopenia in ICU patients? The thrombocytopenia could be due to decreased production of the platelets, increased destruction of platelet, or increased sequestration in spleen and other organs like liver and kidney. So the causes include could be because of drug-induced, which includes heparin, H2 receptor blockers, GP2B3 inhibitors, certain antibiotics, and alcohol. In cases of sepsis, in massive bleeding, and when thrombocytopenia is associated with microangiopathic hemolytic anemia, and the causes include thrombotic, thrombocytopenic purpura, HUS, and DIC. We'll discuss these later. Now, when to transfuse the platelets? The decision to transfuse platelets depend on the absolute platelet count, risk of thrombosis, risk of hemorrhage. Risk of hemorrhage will ultimately depend on the platelet function and the type of surgery the patient is undergoing, presence of active bleeding, and which includes the site and severity of the bleeding, and the etiology of thrombocytopenia. Patients with thrombocytopenic purpura and hemolytic uremic syndrome, they should not be transfused platelets. Platelet transfusion is contraindicated in these patients. The treatment requires plasmapheresis. So these 5 conditions, platelet transfusion is not required. The 5 conditions are 2 I have already told: TTP, thrombotic, thrombocytopenic purpura, HUS, that is hemolytic uremic syndrome, heparin-induced thrombocytopenia, post-transfusion purpura, and catastrophic antiphospholipid syndrome. Now, I have already told you in which cases the platelets is not required. The more important is in which cases the platelets are required. That is the indications for transfusion of platelets in adults. So prophylactic transfusion indications include major surgery or invasive procedure when the platelet count is less than 50,000. Ocular surgery or neurosurgery, that is closed space surgery with no active bleeding when the platelet count is less than 1 lakh. In a case posted for surgery with active bleeding, if the platelet count is less than 50,000, you need to transfuse the platelets. In a case of stable non-bleeding patient, there is a risk of spontaneous hemorrhage, and if the platelet count is less than 10,000, you need to give platelets count. If the patient is bleeding or under invasive procedure and the platelet count is less than 20,000, you need to give platelet. So non-bleeding less than 10,000, bleeding less than 20,000. Now this is a novel TPO agonist, thrombopoietin agonist, L-Trembovac. It should not be used in sepsis patients. Its indication includes severe aplastic anemia and ITP. Usually a question comes on this L-Trembovac. This is a novel new agonist and it should not be used in sepsis. There is no role in sepsis-induced thrombocytopenia. Now let's see about the heparin-induced thrombocytopenia. There are 2 types of heparin-induced thrombocytopenias, type 1 and type 2. Type 1 is non-immune mediated. It occurs 1 to 4 days after initiation of therapy. In this, the thrombocytopenia is mild. Despite continued use of heparin, it resolves spontaneously and occurs primarily with high dose of IV heparin. There is usually no clinical sequelae. As compared to this, in type 2, it is immune mediated. It occurs 5 to 14 days after the therapy of either LMWH or heparin. Thrombocytopenia in type 2 is usually severe and it occurs with any dose of heparin by any route. It rarely causes bleeding problem, but the thromboembolic complications are serious enough, and in this, heparin must be discontinued. It should not be used. Now, I'll discuss about the more serious disorder, which is the heparin-induced type thrombocytopenia type 2. In this, there are antibodies against the platelet factor 4 complex, that is a PF4 complex, and it is induced by exposure to both unfractioned heparin or LMWH. In this, the degree of thrombocytopenia is more severe and platelet falls less than 1 lakh without any clinical evidence of bleeding. But there are thromboembolic complications. Erythema and necrosis is usually seen in heparin injection sites, and systemic symptoms like fever, wheezing, and tachycardia from heparin boluses are seen. Heparin should be stopped, and the patient should be started on direct thrombin inhibitors, which includes lepidodine, which has got renal metabolism, or gatroban, which has got hepatic metabolism, and bivalirudin. This bivalirudin is FDA approved in patients undergoing PTCA, that is percutaneous coronary interventions. Fondaparinux, which is a synthetic factor 10A inhibitor, can also be used. Platelets, as I've told you, should not be given to patients with heparin-induced thrombocytopenia unless there is a severe life-threatening bleeding. So if there is a severe life-threatening bleeding, if the platelet count is less than 10,000, only then they should be transfused, otherwise not. Once platelet count reaches above 1 lakh in a patient with HIT, warfarin therapy should be initiated to achieve therapeutic anticoagulation, and obviously they should be avoided on LMWH and heparins.